Hello, good evening, everyone. We'll be starting shortly our webinar on the skin NTD called lymphatic filariasis. I hope you've had a great weekend. Welcome, Dr. Oiwo.
Yeah, thanks, Dr. Cole.
Yeah, good evening.
Good evening, everyone. So let me just see if we can test run
Your slides, okay.
Yeah.
Can you share your slides?
Let me try now. Suppose it should be.
Yes, that's what it's working. You can see.
Okay.
Can we make it a bit bigger? Okay, you're sharing from your phone. Let me see if we can.
I'm trying to also use my laptop. You want us to adjust one or two things there?
I'm just hoping that it will be, clear enough. Well, I think it's clear enough anyway.
Yeah.
All right.
Okay. So
okay.
let me also try use my laptop to see if that may be a little better.
Okay. Good evening, everyone, and for those just joining, you're welcome to another session of the Skin NTDs training for health workers, and we've had very good sessions over the last 4 to 6 weeks. We've had an introductory lecture. We've had a lecture on, we started with, what did we start with again? I know we've done borrelia ulcer last week, Onchocerciasis, Leishmaniasis, yes. And this week we're doing lymphatic. We're discussing lymphatic filariasis. And lymphatic filariasis is quite endemic in Nigeria and in quite a number of African countries. So it's something that we should all know about, and it's quite, usually quite distinct. But what we want to try to achieve is to be able to achieve as early as possible diagnosis and treatment, and to be able to initiate treatment as quickly as possible so as to reduce the disability that is associated with this neglected tropical disease. And there is also there are so many other paradigms to lymphatic filariasis, which Dr. Sebastian Oiwo is going to be discussing today, this evening. So we hope that a lot more people will join in, so we don't miss out. And then just to remind everyone again that all these lectures, all these webinars are on YouTube. For if you had missed any of them, or you want to just go back and watch what was discussed, or go to the slides to get further information, you can always go to YouTube and watch the previous series or the previous sessions. So we'll just take over from, I'll just hand over to Dr. Oiwo, who is a very wonderful colleague, dermatologist and neurologist at the Irua Specialist Teaching Hospital in Irua, Edo State. And he's also the chairperson for neglected tropical diseases for the Nigerian Medical Association, NMA. So he has a wealth of experience managing infectious diseases, and has the most current details on the national protocol for the management of NTDs. So he's the best person to, keep us updated and keep us up to speed, and let us know what is expected of us as regards neglected tropical diseases, particularly lymphatic filariasis. So thank you, Dr. Onwol, and hand over to you. You're welcome, Dr. Gold, Olufade. Thank you for joining us.
Hi,
Yeah.
Dr. Cole. How are you?
Fine, doing good.
Hi, Dr. O. Good evening.
Yeah, welcome, Dr. Go. Good evening, everyone. Not to waste too much of our time and to just get the ball rolling. Lymphatic filariasis is one of the neglected tropical diseases that is not just only interesting to learn about, it's also important to take note because the stigma it brings on, the disability it brings on, the years lost with disability it comes with, the disease-associated life years that you have associated with lymphatic filariasis is quite important for us to look at. And so today we're quickly going to look at this using this outline. But before that, since it's a disease with so much disability and with so much attention, interestingly, it's one of the two diseases that the Nigeria program for elimination of lymphatic filariasis aims to eradicate before the year 2030. So we'll be coming across a couple of terminologies, which we just quickly want to run through. Control, basically getting the infection or the infestation rather to an acceptable limit within a geographical area. Then of course, disability years, number of years that have been lost to disability, to which of course lymphatic filariasis tends to hold sway here. Disability, inability to live independent life, and also can also be explained by the sort of incongruence between the disease and the person with the disease and the environment. Elimination, there are about three definitions for elimination that will be important to take note of. The one that involves interruption of transmission, that's reduction to zero, that is found in a geographical area with minimal risk for introduction. Then the next of the elimination is elimination as a public health problem. That's achievement of a measurable target. Don't forget the previous we mentioned was reduction to zero by WHO in relation to specific disease. This needs continued action. And of course, for this to be established, the process is called validation. Of course, equity, availability of resources to manage these diseases without any associated differences across gender, social, economic, and other parts of life. Then eradication, permanent eradication. This is permanent reduction, and this is on a global basis, not just within a geographical region, and with no risk of reintroduction. And for this to be done, certification needs to be given to that particular country. Interestingly, Nigeria is hoping that with this target for lymphatic filariasis eradication in 2030, Nigeria will be able to join countries like Sri Lanka, countries like Cambodia, China, and all of that countries, Egypt, that have eradicated this. Of course, extinction, eradication, to which we will not be able to find any sample in any lab, whether in Geneva or any other parts of the country. Integration, we'll talk about this later, when some particular neglected tropical diseases have some specific characteristics in terms of epidemiology, treatment, etiopathogenesis. We tend to pull them together in management plan. That way, that will reduce resource allocation, that will reduce the burden, economic burden of the management. So, to, of course, preventive measures, LF is majorly a disease that can be prevented using chemotherapy. And that is usually the best, because once physical symptoms becomes visible, it may be difficult, except of course, again, patients who have lymphedema maybe in the first or second stage of lymphedema. So we've had this introduction. It's important to note that it's the second most common cause of long-term disability after mental illness. And it's a threadworm. It's an infestation caused by threadworm. And it's important to know, of course, the economic burden associated with it. Estimated annual loss of about 1 billion naira and impairing economic activities of up to 88% of Nigerians. And globally, it accounts for at least 2.8 million disability-associated life years, excluding mental health impacts that it has. Of course, Nigeria had started this program before the global body started this. So Nigeria started in 1999. And of course, we mentioned the strategies. And one of the good news is the fact that 139 local governments have stopped lymphatic filariasis in 19 states. Other important facts that we need to know is the fact that 375 local government areas had reported lymphedema and hydrocele across 30 states. That is as of November 2020. And two major presentations visible, of course, because we do know that lymphatic filariasis oftentimes is usually asymptomatic. As of the time when we start seeing the limb getting to limb swelling, then of course we may be inching close to the chronic form of the disease. And so the two common cause of concern are lymphedema and hydrocele. And so over 3,000 lymphedema and over 7,000 hydrocele has been reported in Nigeria. Out of which 72% of lymphedema cases have been managed in 17 states, and 64.1 hydrocele managed in 22 states. Of course, with respect to the treatment over the preceding 5 years, would see markedly more than 4,000 and more than 2,000 respectively for hydrocele and lymphatic filariasis. Of course, it's good to also note that globally, that about 863 million people in 47 countries are at risk of lymphatic filariasis and will require preventive chemotherapy. And about 8.6 billion cumulative treatments have been delivered to stop this spread since 2000. And important, again, of the good news is that due to these activities, about 74% decline has been recorded since the start of the global program. If we look down on this diagram, we'll be able to see the lymphatic filariasis. This is the WHO Global Observatory on lymphatic filariasis, and this just gives what I've mentioned. Of course, it's good to note the few targets. This may not be a little visible, so apologies for that. That basically just talks about the targets for lymphatic filariasis, and at about 43% of 648 million reduction in the population requiring mass drug administration are being targeted for elimination of lymphatic filariasis as a public health problem. So this just shows a comparison 2018, 2020. Would see that the red areas are the endemic areas. Interestingly, you find out that it's more from the middle belt to more of the northwest as against the south. Like for us in Edo State, Edo State is classified as one of the states that are non-endemic for LF, as you can see on that other diagram. Of course, Ukwaja, interesting thing about this Ukwaja work, apart from the fact that it showed that a third of the population had lymphatic filariasis, apologies for the typo, is that more than 2/3 of them, or about 2/3 of them, believe that witchcraft and causes associated with this. So it's important for us to have an understanding of this disease so as to be able to allay the fear of people. Of course, between Bancroftian and Brugia Malai form of lymphatic filariasis, we've seen various works across various parts of the country, with some studies even talking about co-endemicity of the Bancroftian lower Onchocerciasis, and Manzanella pestans. This, as highlighted, the slides will be made available and would have opportunity. In this work that tends to pull together and looks at the years lived with disability, we'll find out that from the records here, we'll see that the Northwest, which coincides with what we have as of 2022 in Nigeria. This was a study conducted in 2020. And of course, the list is North Central. So to understand this infestation, like I would rather call it, though some places some call it infection, but I think the technical term to use is an infestation. There is a human stage that is often preceded by the mosquito state. Of course, we know that this is caused by mosquitoes, that is the Anopheles mosquito, which is common in Africa, Culex and Aedes that are not as common in Africa. Of course, it's endemic in 72 countries, Brazil, the Dominican Republic, Haiti also have quite a high concentration. And of course, it's important to take note that about 141 million people are at risk of this disease. And so once of this infection, so once we have this understanding and we know that there are two phases, the first two phases are in the mosquito, while the last two phases are in humans. But what really determines community transmission? Because one person can have it and it may not be endemic in the community, but what determines the endemicity, of course, is the proportion of people who have it, the density of microfilaria in the blood, then the density of the mosquito in that particular locality, and distinct features of the vector, infective larvae, and human vector contact. So these are important questions we want to ask from patients who come to us presenting with leg swelling. And usually lymphatic filariasis will present with unilateral leg swelling, which we'll talk about later on. We do know that Victorian Bancrofti is the one that is commoner in humans, though we know that the Brugia malayi have also been recorded in animals. Mealworms, as long as 3 to 4 centimeters, of course, the female worm tend to be longer, and they nest in the lymphatics. So this is important. This affects the lymphatics, while some other infestation tends to have their way through the blood, hematogenous plate. But this is lymphatic, moves through the lymphatics. And it's important to know that the lifespan can be as long as 5 to 6 years, though some other reports have mentioned 10 to 14 years. This is from the CDC and tends to show us more like a cartoon-like representation of the infestation. Would see that lower down, you see lower down, of course, would see from the diagram that the mosquito takes a blood meal, and when it takes a blood meal, the larva enters into the skin. And when it gets deposited into the lymphatics, of course, the male and female, the process go on. There is the release of sheathed microfilaria. And as of that time, another mosquito, once it bites the host, then that takes up the microfilaria, and the other developmental processes continue in the mosquito till the cycle continues over and over. This just summarizes all that have been mentioned and talks about the duration. In humans, you see that this can take about a year, and in the mosquito, 1 to 2 weeks. To have an understanding of the etiopathogenesis, we have to look at quite a few things as highlighted here. We've mentioned the way the mosquito tends to affect the humans. Of course, we'll see that this causes repeated inflammation through production of IgE, IgG, then helper T cell response. This leads to lymphedema, then this causes lymphatic obstruction. With lymphatic obstruction, some other works have also mentioned the role of genetics that predisposes often to more microfilaria in the blood. Then polymorphism of endothelium 1 and tumor necrosis factor alpha have also been implicated as being possible risk for chronic diseases. Wolbachia species tends to live symbiotically with the lymphatic filarial worm. And so in the management of this patient, taking care of Wolbachia species, because again, it provides nutrients to the thread worm. And so if you're able to take care of this, that will help. As I've mentioned, usually lymphatic filariasis is usually asymptomatic. But of course, the early phases of the symptoms that would have may just be a period of fever and tender lymph nodes, which at times tends to recur over time in what has been described in the technical terms that are being called acute dermatolymphadenitis. And of course, other features that they may also present with is the acute filarial lymphangitis, the dead adult worm, leading to mild clinical symptoms and rarely causes lymphedema. Of course, at this stage, even if there's going to be lymphedema, we're going to have lymphedema stage 0. ADLE, like I've mentioned, is reports, it shows experience of recurrence of attacks, which are considered to be the main risk factor for development of lymphatic lymphedema and elephantiasis. Of course, the filarial lymphangitis often precedes the onset of ADLE, and this suggests that lymphatic filariasis could be a risk factor for secondary infection. Another important aspect that recent work I've looked at is severe interdigital lesion associated with laboratory evidence of filarial infestation, the number of lesions, which often has been said to be the strongest predictor of frequent acute dermatolymphadenitis. Other clinical features can also include involvement, swelling of the particular parts of the body. It can, if it involves the breast, there will be enlargement of the increase in the size of the breast. If it's a limb, there's increase in the size of the limb. It can also affect the kidneys through deposition of immune complexes, which at times can also present with chyluria. You look at the urine macroscopically, one would see chyluria, like this milky kind of urine. Then the genitals can be affected, swollen genitals, because there's deposition of the worm in the tunica vaginalis. The tunica vaginalis, and this causes the presentation in that area. It's also important to know, of course, that we can have occurrence of 2 to 3 times of these presentations in a year, and they can be quite painful and disfiguring. Mentioned that can affect the genitalia, the breast, the vulva, and other parts of the body. This is a 14-year-old patient we saw in our clinic who presented with unilateral leg swelling, was sent to the lab, and results returned positive for microfilaria, and we have started him appropriately on the drugs. And as of the last review, there seemed to be some limb reduction in limb swelling. It must be noted again that one feature that helps one differentiate lymphatic filariasis from all other causes of limb swelling is that usually it causes unilateral, a limb swelling, as against the closest twin of it, that is podoconiosis, which usually affects both limbs. And then we'll see that in the early phase of lymphatic filariasis, there could be pitting, but as we move to like stage 2 and stage 3 of the lymphedema, we'll find out that it becomes non-pitting. And of course, we also see other features that would help us differentiate this from other differentials of unilateral leg swelling, cellulitis, even trauma, which of course we don't want to shove aside, and also look at other congenital causes of lymphedema as we deal with later on. Like I mentioned, this is involvement of the various parts of the body. Would see in this patient who has giant elephantiasis with inguinoscrotal hernia, and this was successfully repaired. And so it can affect any part of the body. It can affect the scrotum with hydrocele, as seen in this diagram, can affect the breast, can affect as many parts of the body as previous studies have reported. What are the differentials? I've mentioned podoconiosis, bacteria deep bacteria or fungal lymphadenitis. Then, of course, we want to also be sure whether this is a primary lymphedema or a secondary lymphedema. Primary lymphedema, if there had been some congenital abnormalities with the lymphatics, or secondary injury to the lymphatic system, either from previous surgeries, radical excision of lymph nodes, to which these symptoms may begin to develop there about a year after that. Then other differentials of those lymph swellings, lymphosarcoma, then if it affects the scrotum, we'll look at carcinoma of the scrotum. They have mentioned cellulitis. I've mentioned other differentials of unilateral leg swelling. Then, of course, we also will want to know, because some patients will present with bilateral leg swelling, to which is not a common presentation for lymphatic filariasis. Bilateral leg swelling would rather be more common with chronic organ failure or diseases like congestive cardiac failure, chronic kidney disease, chronic liver disease. Then, of course, we also want to look at other differentials of the lateral leg swelling. Patients that have deep fungal mycosis, Madura foot, can have unilateral leg swelling, but that difference is that there will be discharge of sinuses, there will be discharge of colored fluid coming out, and depending on the species of the fungus that is involved, the color will vary as well. Of course, patients who also has Kaposi sarcoma would also present with unilateral leg swelling. Other differentials that would also want to rule out involves involvement of the hematogenous system. You know, this is lymphatic system. We can have patients who have capillary malformation, lymphatic malformation, patients who have lipedema, deposition of fats. It must also be noted as well that it's important to know these various differentials to guide the investigation. We do know that the standard for investigation is microscopic examination of the microfilaria using Jepsen stain. Other investigations which could be supportive, lymphoscintigraphy, in which technetium sulfur colloid injection is injected, and after about 45 minutes, then 2 hours, we'll see the flow. If there's an obstruction, one would not even be able to trace the flow of the technetium. PCR can also be done, antibody. Then ultrasound can be used to detect the movements of the adult worm and lymphatic obstruction. We've mentioned chyluria. We must also note that there is the occult lymphatic filariasis as highlighted, important of which is to also note the glomerulonephritis. Management along the public health response, we look at the mapping, mass drug administration assessment, and other lines as highlighted. And this I've mentioned before, the pillar of management lies on drug control, morbidity management, and integrated vector management. Basically, the prevention is by the use of albendazole and ivermectin. And this is given annually for about 5 years so as to cover the parasite, as some as once a year may not suffice to take care of the adult parasites. It's also important for us to note as well that we need at least 5 years of this to be able to achieve effective response. And this is by greater than 65% of therapeutic coverage of total at-risk population. We've mentioned this success story. And in recent times, the combination of albendazole, ivermectin, and diethylcarbamazine has also been recommended by WHO because some works have shown that this helps to clear the microfilaria faster within weeks as compared to the annual dosages for 5 years that would also would have. All that management, of course, is at the level when lymph swelling occurs. We would find out that there is no, we'll realize that all that needs to be done is to care for the limb, advise the patient to bathe the limb and not neglect the limb. Lymphatic filariasis is already a neglected tropical disease, And so the patient should not neglect the limb, because we know that if the limbs get infected, it will cause more inflammation. With more inflammation, there is more lymphatic obstruction. And this is what we teach the patient usually, not to neglect the limb. And vector control, what can be done for malaria control can be piggybacked upon to help with vector control in lymphatic filariasis. Of course, another important aspect is assessment of the areas, and this can be done using the antigenemia and microfilariemia and the various criteria as highlighted. And if an area is endemic, all these criteria would have yielded more than 1% in that particular area. And this mapping tends to occur if there are preceding contradictory reports and mapping was conducted later than preceding 10 years prior to that time. It's important to note that all hands must be on deck across all disciplines. Doctors, nurses, pharmacists, community health workers will work together to ensure lymphatic filariasis is appropriately taken care of. This is cross-cutting approach that WHO has advised and looks at the various aspects of the health system that would contribute their various parts into policy formulation, into research collaboration, human capacity development. And another important point is look at the 5 root cause analysis in evaluation of lymphatic filariasis, and this usually helps in program coordination. And some other integrations of diagnostic tests, usually better, like I mentioned, integration is better to look at various infestations or NTDs that have the same ethopathogenesis and maybe treatment. And we can, as we see here, would see that lymphatic filariasis fits into microscopy, serum testing, PCR, and rapid diagnostic test. And this also appears the same for quite some other NTDs. Potential research areas in terms of the epidemiology, in terms of the assessment of the vector, in terms of the acceptable drug that is found to be better in a particular area amongst all that. And when we do all of this with the mass drug administration, vector control management, morbidity and mortality management, would have been able to achieve the sustainable development goals as targeted for 2030. And so concluding, it's important for us to know that lymphatic filariasis is best prevented, because once the limb starts to swell, it may lead to just continuous management of control. And if the patient is best assessed and needs surgery, the surgeon is called upon, the plastic surgeon is called upon, who can decide to do a lymphovenous anastomosis or can decide to take viable lymph nodes from other parts of the body, implants them into the specific affected area with their lymphatic vessels, and that also helps. Then other treatment can also involve clearing of redundant tissues and even using some of those redundant tissues as grafts. These are my references, and I want to say thank you for your order.
Thank you so much, Dr. Seb, for the very, very well presented topic. And I already have some questions in the Q&A box. I was going to start answering them, but I decided not to because we only have one question. So, you know, when they say it's either a presentation is so clear and, you know, you don't really have much questions. And I think that is what has happened in this case because you presented it so lucidly. Thank you very much. So the question from this anonymous attendee says, please, when requesting for ultrasound, what part of the body is scanned in order to visualize the moving worm?
All right, thank you very much, Dr.
Yeah.
Thank you, Dr. Cole. I want to thank the person who asked this question. Well, it's important to note that of all the investigations, the most important aspect there is to view the microfilaria in the blood. All these other tests usually can come maybe for research purpose or can also come with specific indications. Possibly the expert wants to also look at other aspects in relation to maybe surgery, prognosis for surgery, and a few other things. So to answer the question, it is a specific area that is affected. If it is the lymph that is affected, of course, one would want to look at the lymphatic drainage of the limbs, even from the potential source of possible inoculum, if we can call it, down to the inguinal lymph nodes. We'll be able to trace it through that area. So that is important, but it's important to state again that all those other ones will rather be termed under ancillary investigations, as the most important investigation is to visualize the microfilaria in the bloodstream. And this is, I need to also add that to successfully visualize, the sample need to be taken at night, because lymphatic mucosal bankruptcy exhibits what we call nocturnal periodicity. So if samples are taken during the day, we should not be surprised if we do not get any results. So usually better to take the sample in the night. Thank you. Nocturnal periodicity, like I said, you see the microfilaria more in the lymphatic system in the night. So that's just lymphatic, that's nocturnal periodicity. Nocturnal in the night, periodicity, the times it comes into the lymphatics. Thank you so much.
I think Dr. Seb, I think the attendee, Dr. Lawal, was just, Fahad Lawal, who said, what's the nocturnal periodicity? I think he was probably asking about the time. You know, like, is there a specific time during the night, you know, like, you know, whether 6 to 10 or something, that is there specific? Is there just, Dr. Lawal, please, can you follow up on that question, just to be sure that that your question has been properly answered?
It's all right. Thank you. So while we wait for Dr. Lawal to specify, because I tried to answer that, I also want to answer the other questions about drug of choice. Well, typically what is used for mass drug administration is albendazole and ivermectin that are given annually. And I've said that this is given in 5 successive years so as to be able to achieve about 65% coverage in endemic areas. Can doxycycline be added to the drugs? Yes, because of the Wolbachia species. And the difference between doxycycline and the ivermectin and albendazole is the fact that albendazole is given once in a year. But because you want to appropriately take care of this rickettsia-like bacteria, you would ask the patient to use doxycycline for about 4 to 6 years. I've mentioned albendazole, ivermectin for 5 years annually. What's the gold standard for filariasis? I've mentioned that you visualize the microfilaria in the blood, though other treatment options, other investigations have been highlighted, but it will be very important to hear view from others, as we also have lab experts here. As a primary care provider, do I request for just blood microscopy from the lab after taking the sample at night? You request for blood for microfilaria, so that, and of course, it is also expected that you give a brief history and possible diagnosis that you're considering. What's the difference between lymphatic filariasis and onchocerciasis based on laboratory diagnosis? Well, like lymphatic, they are both neglected tropical disease, one, and of course, like we have said, blood film for microfilaria is rather used for lymphatic filariasis, while for onchocerciasis, especially if it has to affect the skin, we'll talk of the skin snip. Then I mean lab test. Okay, is it not advisable to take albendazole quarterly to eradicate LF? Well, as for the program in Nigeria, this is what I know: annual albendazole and ivermectin, even especially for non-affected, especially for associated community members, even those that do not show symptoms. Though, of course, depending on the assessment of the expert can now decide to adjust as appropriate. You said there's no drug proven to cure lymphedema. Why the treatment in many cases focusing on limb reduction? Well, there has been no, especially when it gets to the level of limb swelling, there hasn't been any satisfactory drug. Majority of the treatment for limb swelling is to maybe passively ask the patient to raise the limb, and with the assessment of the experts, it can liaise with the plastic surgeons who would decide on the best modality of that. Then, of course, that is also in addition to compression stockings that's also been advised, as well as other care to which you want to tell the patient to take special care of that particular limb. That shouldn't be, as much as possible, reduce injury to that limb, as much as possible, avoid the use of the advice from some other sources have also been that reduce use of the limbs on activities that would involve repeated movements of that particular limb, in quote as it were. Then can crepe bandage be used to reduce limb swelling? Well, in the real terms, there are specific what looks like thromboembolic deterrent stockings that are specific for the limb size and are specific for the limb volume. And when I talk of the limb volume now, we talk of assessment of the volume, to which tape measure can be used, but most work have said that is not specific. Some have talked about displacement of water and a few others, but there are specific stockings that are used for this. In settings where this is not available, we could try crepe bandage, but care needs to be taken so it doesn't become too tight as to also obstruct blood flow in the limbs. Kindly share the slides, especially the one on potential research representation. That would be done. I think with this, I have answered all the questions.
We have one last one, Dr. Seb.
Okay.
There's one that says, please, sir, is diosmin still in use in management of lymphatic filariasis?
Well, I am not conversant with diosmin, at least in recent times. So maybe the person who asked the question could elucidate further on that. That would be very nice.
Thank you, Dr. Seb. I actually have a question as well, Dr. Cole.
Okay.
So, is there any particular criteria for communities, to qualify for MDA? For instance, if a case or two are reported in a community, does that, make them to qualify for mass drug administration, or are there some other specific criteria? So that if, for instance, if people diagnose lymphatic filariasis in their community, is there a process to follow to apply for, or to, aside from notification, to, be able to apply or request for MDA, that's mass drug administration, in their community? So that's what I would like to know. Thank you.
Thank you so much, Dr. Cole. The process, once we have every diagnosis of lymphatic filariasis should be reported to the local government NTD officer, and the local government NTD officer will cascade this to the state, and the state cascade this to the region, to the national level. There is what is called pre-transmission assessment survey, pre-TAS. Then there's also transmission assessment survey that is done. Then after that can also be done. And so when this is done, when there's a report, then with the cascading of information, endemic communities are set. And the assessment are a few things I've tried to put in place. The criteria would include, of course, we want to do mapping. You map the area, and I think to the best of my knowledge, I think mapping has been done for quite all the local governments in Nigeria. So once that has been done, then the endemic local governments can now, the pre-task, the task can now be carried out on the specific area. And few things that can be used is the antigenemia, microfilaria, and a few other information that would be asked. And these are usually done by the NTD officers in collaboration with co-opted members of the team that may include community drug distributors and a few others, as the case may be, depending on what the task assessment says.
Okay, thank you so much. So it just highlights the importance of notification, because that's the first step, that if we do have cases, it's important to make reports to the local government so that that process can then be started. From what I understand by what you said is that once those reports are, escalated, then an assessment of the community can be made, to determine the level of endemicity that that community may have. And that's what will determine MDA, mass drug administration for that community. So if the reports are not made, that process may not, be cascaded. And so the fact that these cases are being diagnosed and reported is of utmost importance for, progress in the eradication or the elimination of these kind of NTDs. Thank you.
Thank you, Dr. Cole. I don't know if there are other questions. I think someone was asking a question about how long. I think Dr. Gold has tried to answer that.
I was just about to answer, but I didn't answer. So I think you should just answer since you've read it now.
Okay, yes, I had mentioned that the duration, of course, depends on the level of the presentation, the severity of the lymphedema, and whether or not the person already falls within the endemic area or whether or not the person has symptoms. So it's not a straight-jacketed thing, but for prevention, the mass drug administration involves yearly administration of ivermectin and albendazole for 5 years. But for the particular individual that presents with lymphedema, a combination of modalities can be used: drug management, passive treatment. Then if assessment warrants review by the surgeon would start appropriate treatment, which includes surgery if there are other specific drugs that can be used. But suffice it to say that once it gets to the level of lymph swelling, it looks like the picture looks pretty not too fantastic, except of course we are still in stage 0 or stage 1 of lymphedema, in which stage 0 entails you have the microfilaria but no lymph swelling. Stage 1, there's lymph swelling, but it goes back. It can reduce by elevating the lymph. Stage 2, there's elevation. Then stage 3, there's skin manifestation. There's fibrosis of the underlying layers of the skin. And so the more the severe, the more it gets beyond stage 2, the more difficult the return back to normal life would be. And of course, the more severe it is, also I don't know what to use the word, the worse the prognosis really, because in terms of severity, once we see that lymph swelling affects less than 20%, there's increase in lymph volume less than 20%, that is mild. When we have about 20 to 40% increase, that's moderate. Then severe is when we have 40% increase. So it's not a straight-jacketed answer. It depends on the assessment of the expert. So what would happen once you have this patient, in addition to the drug you want to administer, refer the patient to the nearest dermatologist, who would also liaise with the plastic surgeon as necessary to institute appropriate management.
Thank you, Dr. Seb. Thank you so much. I think you have answered all the questions, and I don't think there are any more questions or comments in the chat box. And as usual, this has been a very enlightening session. I'm sure you would all agree with me. So the next session is supposed to be in 2 weeks again. Dr. Cole, I don't know if you have any more comments before I close the meeting for today.
No, because I want to just thank Dr. Seb for a very lucid presentation. And just to remind people that all the presentations are on the YouTube channel for you to go through. If Dr. Seb permits, we can also send the slides with the post-webinar email. So those are, you know, but if not, then you can always watch the presentation again, or, you know, the highlights, the points the parts of it that you're interested in, or the whole thing via YouTube. From tomorrow, it will be uploaded on YouTube by God's grace. So thanks everyone. Yeah, so over to you.
Can you mention the name of your YouTube channel again, where they can get it?
Yeah, so it's actually I'm not sure of the exact name, but if you just Google Dr. Fola Cole-Adeife, it will come out, and then we usually add it to the post webinar email. So if you get the post webinar email, you'll be able to get the link there. So, but also check Dr. Fola Cole-Adeife on YouTube, and you'll be able to get all the videos on that YouTube channel.
Yeah,
thank you,
sorry,
Dr.
Dr. Gold, someone asked a last minute question, Michael Joseph. He said, apart from swelling, are there any allergic symptoms? Well, because it's a parasitic infestation, we expect some form of allergic reactions. If you saw in the slide, allergic reactions in quotes now, please just put it in quotes. Tropical pulmonary eosinophilia would see pulmonary infiltrates in the lungs, and that is also part of some of the reaction of the body to either the dead covering, the covering of the dead worm, or of course, as a result of repeated cascades of inflammation and inflammatory cytokines and antibody release. Then, of course, we would know that in some of the phases, depending on the genetic predisposition of the individual, who knows, the person could also react to some of the drugs given. So never say never, but some common ones that have been talked about is tropical pulmonary eosinophilia that tends to give what is classified under occult filariasis. In that, you may not even see microfilaria in the blood until you look at it, check the lungs, you may just see a few of that. Then what's MAM? Well, I tried to put that in the presentation. MAM is mass administration of medicine. LF is lymphatic filariasis. So LF, MAM, lymphatic filariasis, mass administrator of medicine. I tried to put the meanings of each of the abbreviations at the first use. So it's possible this person is seeing this at the other times when the abbreviations are used. Thank you.
Thank you so
Thank
much.
You so much.
Oh, okay.
Yeah, I just wanted to also, I forgot to mention earlier that these webinars are facilitated by the International Foundation for Dermatology and the International League for Dermatological Science Societies, ILDS and IFD. And they have expressed their happiness that people are, actively learning about skin NTDs. And we will soon get to the phase where we'll start having like practical sessions using the apps. So if you have photographs or you see cases, you can just take the pictures, and then when we begin to use the app to practice, you can use that to send in photographs of skin conditions or possible skin NTDs that you see in your communities for discussion, either during the webinar or using the app at other times. So the aim is that we are more practical, that we don't just think about these things and throw the knowledge away. We want to be able to put that knowledge into use in all our various communities with the aim of reducing the prevalence of the skin neglected tropical diseases in our various communities. So we thank the IFD and the ILDS for the opportunity to host these webinars, and also to have like some and a mobile app that we can also use as a form of practice, of what we have learned during these webinars. So just to mention that. So on that note, I hand over to Dr. Gold and Dr. Oil. If they have any other notices, and then we can end the meeting today. Thanks.
Dr. Ewo, anything you have?
Nothing else, just to re-emphasize what I've been talking about. Once you see any case, don't sit on it. You need to contact the expert, contact them, then also report to the coordinators and all. Thank you.
Thank you, Dr. Oiwo, for the wonderful presentation. Even though lymphatic filariasis is something I've known, I've learned something new again today. Thank you very much. And to all the participants and the attendees, thank you. We wouldn't have been able to do this without you attending. Dr. Cole, thank you for bringing this together once again. Have a lovely week, everybody, and see you in 2 weeks' time again. Bye.
Bye.
Bye-bye.
Bye, everyone.
Bye-bye.
Bye-bye.